Good afternoon and welcome to Psychiatry Grand Rounds. There is no commercial support for today's program. The planners have disclosed no relevant financial relationships with commercial interest. Our speaker will announce his disclosures. If you have a question for our presenter, please hold until the Q&A segment at the end of the talk. And if you're attending virtually and have a question, please enter it into the Q&A bubble, and we will ask that at the end of the program. We will also be sharing an evaluation link at the end of the program. It is my pleasure to introduce our guest speaker, Dr. Andrew Nierenberg. Dr. Nierenberg is the director of Dauten Family Center for Bipolar Treatment Innovation at Massachusetts General Hospital, holds the Thomas P. Hackett, MD, Endowed Chair at MGH, and is a professor of psychiatry at Harvard Medical School. In addition to directing the Dauten Center, Dr. Nierenberg is the MGH Center for Clinical Research Education co-director and associate director of the Depression Clinical and Research Program. Dr. Nierenberg focuses on clinical trials for bipolar disorder and depression with over 615 published papers and a Google Scholar H-index of over 130. He has been listed among the best doctors or top doctors in America for the treatment of mood and anxiety disorders yearly since 1994. He has been honored with the International Society for Bipolar Disorders Mogens Show Award for Research and the Brain and Behavior Research Foundation's Colvin Prize. Dr. Nierenberg is currently the PI of the Sequential Multiple Assignment of Treatment Study for Bipolar Depression, funded by the Patient-Centered Outcomes Research Institute. He is also leading the Bipolar Action Network, a learning health network of multiple healthcare systems that breaks down the barriers between clinical, research, and quality improvement activities to get better outcomes. Dr. Nierenberg has an active clinical practice, supervises and teaches residents, serves on multiple nonprofit advocacy group boards, is on multiple journal editorial boards, and is the editor-in-chief of Psychiatric Annals. Please join me in welcoming Dr. Nierenberg.
Thank you so much for that kind introduction. I wish I could be down there. It wasn't possible for me to travel this particular week, but really appreciate you all being there. And perhaps unlike other grand rounds, I'm going to challenge you to think differently about how you think, how you know what you know, how you learn, and how you go about trying to always be better. In that context, here's the title, right? You can read it for yourself, and it's really along the lines of thinking about how we go about doing our business in helping people, particularly with bipolar disorder, but even other people with psychiatric disorders, and how we could think of changing the model of what we do through something called the Learning Health Network. And that's really what I want to be able to share with you today. I've worked with many companies over the years, and there's just a subset of these in the past 24 months, but it'll have no bearing at all on what I'll be presenting. So here's the real question. We deal with complex chronic disorders, and I think bipolar disorder is prototypical for that. People with bipolar disorder have the most other disorders. They have the most comorbid conditions, both psychiatric and medically, out of all the disorders. And these people are very complicated. And in one sense, what I'd like you to think about is the word epistemology. Now, epistemology is the study of knowledge, of how do we know what we know. And I'd like you to reflect on how do you know what to do when you're faced with a patient with bipolar disorder What's the evidence base that you generally use? How do you integrate other information? And most relevant for this talk today is how can you learn from every patient encounter and be able to not just learn from your encounters, but everybody in your system, and then even from multiple systems. So that's what I want to leave you with at the moment. So first of all, a learning health network has three English words that individually you can know what it means, but what is a learning health network? Fundamentally, it's an organization, and I'll show you some examples of these, where everyone in the organization is able to rally around a central focus on getting better outcomes. And if you think about your own experience with trying to get better outcomes, I know from reflecting on before I got involved with this, never really thought about it, and never really thought about, well, what are the outcomes of my patients, and what are the outcomes of my colleagues' patients? What is it that I can learn from them, and what could they learn from me? There's really no infrastructure for that. And the Learning Health Network starts to give an infrastructure for that. And part of this is really forming a community where everyone in this community across multiple healthcare systems starts to know each other, and that it uses a sophisticated organizational principle called an actor-oriented network. In an actor-oriented network, everyone can contribute and innovate without having permission to do so. So this isn't a research study with a protocol where everyone is supposed to follow the protocol, but it's an organization where if anyone, including patients, families, clinicians, researchers, data analysts, and so forth, can have an idea and test that idea, can have an observation and potentially spread it if it's really going to help people without necessarily having to go through a randomized clinical trial. Now, it can be used as an infrastructure for randomized clinical trials, and I'll tell you about that a little bit later. But fundamentally, the philosophy is that it's constant learning, constant sharing, and that the learning arises from the data that comes out of every clinical encounter, and it's aggregated. And again, I'll show you a little bit about that. The other aspect of it is that there is a whole science of improvement, and there is a science of how to improve systems, how to change systems, and we have experts within the Bipolar Action Network to be able to guide us of how do you do that, because it's very daunting, right? How do you possibly change a system of care? And in fact, before I got into this, I never even thought of what I was doing, what my colleagues were doing was in the context of a system. We really weren't thinking in terms of systems. And then the other idea is that if you can get multiple healthcare systems to agree to share their data, to share their outcomes, it actually becomes an opportunity to be able to learn from the actual data and the variations in outcomes across multiple systems. And so this, in a nutshell, is the idea of a learning health network. And the other idea is that this is not patient-centric. This is people-centric. That is, all the people involved need to have a benefit from this. One of my colleagues who I work closely with from Cincinnati Children's, Peter Margolis, has really taught me that that the nature of these networks allows everybody to do these particular activities on the slide, but also they have the opportunity to lead. And I'll tell you some stories about that that's happening in the Bipolar Action Network from people who have lived experience, experts by experience, who live with bipolar disorder, who are leading initiatives. And the other idea is, it's a peculiar word which I had never heard before, but it's to co-produce care. And it's to co-produce a better system of care so that the patients have a better experience and the clinicians can have a better experience also. Now, this is all predicated on trying to get the information that you need. That's why I was talking a little bit about epistemology, right? Because one of the challenges that we have is, well, you know, there are guidelines. And if I was there, I would ask you all, when's the last time you actually used a guideline, consulted a guideline, actually looked at it? Did it actually help you in your decision making? And I've talked to many healthcare systems, up to 27 and even more now, and none of them really have a system that facilitates people using the best available evidence. And so part of the Learning Health Network is this, getting what is needed when it's needed. And it's how do you do that with radical collaboration? And again, I'll give you some examples of that shortly. So one of the things that I learned was that Cincinnati Children's, through the Anderson Center for Healthcare System Excellence, has built 15 learning networks. And these learning networks range from complex chronic diseases, and I'll show you some of that, to even improving the well-being of third graders in Cincinnati, like 66,000 third graders, and they were able to successfully improve their well-being. But I'm going to show you two that are really the prototypical learning health networks, so you can get a sense of what this is really about. The oldest and most established of these networks is called Improve Care Now. And Improve Care Now focuses on children and adolescents who have inflammatory bowel disease, Crohn's, or colitis. Now, as a psychiatrist, I certainly don't know a lot about these gastrointestinal diseases, but when they started, the field was really disorganized, fragmented. There were all sorts of treatments that people were kind of using and kind of not. Nobody knew their outcomes. Nobody knew the outcomes in any particular clinic. And I would be interested to learn from you all, do you know what the outcomes of your patients are? Right? Do you have a place that you can look at it, track at it, see what's going on? Well, what happened with Improve Care Now is that it has grown over the past 17 years. It's currently over 100 clinics, somewhere between 30,000 and 50,000 kids. And each of the clinics can actually see how their patients are doing in aggregate. And the different places can also see how the network's doing in aggregate. Now, only individual places can see the personal health information from their place. No one else can see that. But one of the things I can tell you in this journey of putting together the Bipolar Action Network is that the data sharing drives the lawyers nuts. I mean, it really takes a long time for the legal agreements to actually share data amongst the different places. It's doable, but it's certainly challenging. But what I want to show you is really an astounding outcome from this. Now, remember, inflammatory bowel disease, Crohn's and colitis, very complex chronic diseases that involve complex and complicated treatments. And so what they did was they first found out like what is going on. And in the land of learning health networks, that's called situational awareness. So when they started, the initial remission rate was around 55%. And when I say initial remission rate, it was for an acute GI event, right? So if there was an exacerbation or something like that, and about half of these kids would recover from these acute bouts. And what they did over time was they looked at what the outcomes were across multiple places. They found that there was variation in those outcomes. And because they built a community around humility, generosity, curiosity, they were able to have it so that the places that didn't have as good outcomes as other places went to the places that had better outcomes and just asked them a simple question. What are you doing that we're not doing? Please teach us. And then using improvement techniques, they would take those learnings and improve what they were doing. And they had this increase in remission, right, which is staggering, from 55% to greater than 75% with no new treatments, right? So they were able to actually improve the outcomes substantially. And even today, they continue to have constant improvement, both in terms of the process of care and as a result of improving the care, of being able to have better outcomes. The other thing that the Improved Care Now network does is they use their platform for clinical research and clinical trials, and they have somewhere around 20 to 30 concurrent trials going on at any given time. So it's really massive, and it's a massive radical collaboration to get better outcomes. The other prototypical learning health network is called Solutions for Patient Safety. And this to me is extraordinary. They have 150 children's hospitals who have agreed to share the data about everything bad that happens in the hospital. And can you imagine what the lawyers do with that, right? I mean, it's extraordinary. And the reason they did this, and the reason they agreed to it, is because they wanted to reduce bad things from happening, and they wanted to learn from each other about this. And so using the same technique, let's see what's going on. Let's collectively decide what's important to track. Let's look at the variation between systems, use those variations as an opportunity to learn, and then use quality improvement techniques to actually change what's going on. And I will show you just one of many of their results. And again, this is extraordinary. This is called a statistical run chart, right? And what they look at they're constantly looking at the data, and they can actually look at this in real time. And they were able to reduce the adverse drug event rate by 65%. 65%, right? I mean, that is just absolutely extraordinary. And they've done many, many other things to make the lives of everyone in those children's hospitals better. Not just the patients, but even the people who work there, the families, and so forth. So this is really the extraordinary power of the idea of putting together a learning health network organization. And this has been done somewhat in psychiatry in a limited way. Amy Kilborn from Michigan and colleagues have looked at learning health systems. And the difference between a learning health system and a learning health network is that the structure of the learning health system is just contained in one place, right? And so you have everyone trying to learn from each other in one place, and a network is multiple places trying to learn from each other. That's the difference between the two. And the whole idea of having a network organization in part comes from Øystein Fjelstad, who's the former dean of the business school in Oslo, Norway. And what he showed was that in businesses and now in healthcare, if it's reorganized so that purpose is at the center. There's no single organization, there's no single person who's at the center. It is the purpose at the center, and that everything is driven laser-like to address that purpose. And if that is done, it turns out that all organizations that follow that end up doing much better than compared to a traditional hierarchical system. Now, in my system, which is enormous, I mean, it is just gigantic. We've just reorganized so that we have one department across 3 hospitals, Massachusetts General Hospital, Brigham and Women's, and McLean. We have 1,400 faculty, which is, astounding. And it is very much of a hierarchical, classic sort of thing. And I'm trying to make trouble by injecting this sort of learning health network that's a flat network. It's a flat organization with purpose at the center. And just recently, a couple of months ago, this was published in the New England Journal. And it also shows, with my colleague Peter Margolis as a co-author here, that how do you have a commitment to actually transform healthcare for better by thinking about putting together a learning health system. And the other thing that also just came out is that from Robert Califf, who is the former FDA commissioner, is that we can use real world data not only to improve care, but for research. And that's one of the things that we are able to get through a learning health network. All right. So this really has a lot of traction. And the Center for Medicaid and Medicare Innovation is very interested in having these learning health networks grow, again, because they have a proven track record of getting better outcomes. Now, what I'm going to show you is sort of a schematic, and I'm going to hone in on it because otherwise it's very hard to read. But I just wanted to give you a sense of how these things are organized, and you'll see that there are 3 arrows that focus on outcomes. One is to build the community, and building the community is essential. You cannot do this by fiat. You can't do it top down. You can't do it like you have to do this. It has to be a desire to get better outcomes. And if a place does not have a strategic priority to get better outcomes, this is not the right thing for them. And then what happens, you build systems for improvement capability, right? So you build a system so that there are ways to improve things. And then there's the shared data for learning. And what each of these concentric circles are, there are network activities and the infrastructure to support collaboration. There's the network activities to implement system change. There are the individual care activities to enable practice change. And then there's the care center activities to actually change the outcomes. So what I'd like to do is let's focus in on a couple of these things, right? Here's what I just told you, what they are. But I wanted to focus on the care center activities. And here's where it starts to become radical, right? Co-produce care. What does that actually mean? That means to sit down with the patients and go, hey, how is this working for you? How's the system working for you? Are there things that we can do collaboratively better? If we decide that it makes sense to measure things, what is it that we really ought to measure? What's important to you? And what's going to help you in your care journey? The other thing is to enact population management. And I can tell you in my center, we treat about 430 people with bipolar disorder. And we have never known the outcomes of those 430, and we're just learning that now because we're gathering the data for that. We also want to coordinate care effectively. One of the things that we do a very poor job of, I'm talking about my place, is we don't coordinate care with all the medical problems that people have. It's really disjointed. It's ad hoc. It's like, okay, somebody has a cardiac problem, you send them to the cardiologist, but or they may have a cardiac problem and they saw the cardiologist on their own and never quite told you what was going on until they came to see you and you look it up, right? So you want to coordinate care better. The systematic screening and accurate diagnosis, out of the 27 places that I talked to, one was doing really systematic diagnosis. None were really doing systematic screening, although there are many systems now that use the PHQ-9. That is not systematic screening. That's sort of a depression thing. And very few places will actually screen the depressed patients to see whether or not they have a history of mania or hypomania. The other thing is most places really don't track outcomes, and that's kind of under this category here. The right treatment at the right time, how do you know? How do you know what people are treated with? How do you know if the treatment that the people in your system are giving is appropriately concordant with guidelines? Now, it's really important that the whole area of quality improvement is not to assess if people are not concordant with guidelines and therefore you beat them up. It's really to learn from it. And that if you start to learn that if you're concordant with guidelines, you get better outcomes, that's a motivation in and of itself. And by the way, I was shocked to look at the literature and ask a very simple question, which was, if you follow guidelines, do you get better outcomes? And I could find one paper that basically said, if you use first-line treatments for mania, you get better outcomes than if you don't. But otherwise, it's an assumption, which is really fascinating, which goes back to epistemology, which is how do you know what you know? And how do we know what we know comes from randomized clinical trials that don't include our patients, because our patients are excluded if they have suicidal ideation, behavior, substance use, or comorbid conditions, right? So it's like, well, then how does that work, right? And what is it that we need to do from them? So really the whole purpose of this is to shift the learning and to shift it from what we've all heard about all these years, which is evidence-based medicine, and to shift it to medicine-based evidence, to actually look at what's learning for whom and to be able to do that. Now, by the way, one of the things that's on the close horizon is to be able to look at the data and have it so that if you see a patient and you put in the variables of your patient into the electronic medical record, what can pop up is here are 5,000 patients just like yours. Here's what they were treated with. Here is what the outcomes were. And here's a medicine-based recommendation for you to help your patient. I mean, that system, by the way, already exists in Stanford, although it's done in other areas. And I think they spun off a company to do that or something. But we are, I would say, maybe 2 years away from being able to implement something like that, which to me as a clinician would be just great. It would really help me a lot, especially when I'm facing difficult situations. So this is how I tried to summarize it and try to summarize my particular journey with understanding it. So you have an unrelenting focus on getting better outcomes. That's the aspirational, bold goal. You got to build that culture of curiosity, generosity, humility, an openness to learn, and most important of all, a desire to improve. And not only on an individual level, but on a system level. Who doesn't want to improve? Who doesn't want to get better outcomes? Right? But it's been interesting to talk to some healthcare systems and say, well, our outcomes are going to be worse than anyone else because we see sicker patients. But it turns out all the systems say the same thing. So again, because that's where the curiosity and humility comes in. It's like, let's find out what those outcomes are and figure out what's going on. So then we have to collect and share the data about the process of care and outcomes. And you have to get the lawyers to stop killing each other about data sharing and privacy and all of that. And there's a way to do that. It's just a long journey. Then we learn from the variations in data, which is what I told you before, right? You find variations across systems. That's an opportunity to learn. Then you test those changes that you want to do, that you learned from the variations in the data, and you test those changes in the system of care. Then you assess the changes in outcomes and quality improvement cycles. You do plan, do, study, act. And if something is not working, you get rid of it. If something seems to be working, you say, great, we're getting better outcomes. Now how do we spread it? And then you rinse and repeat. This is the actual process that underlies it all. So over the past 2 years, my colleagues and I, and I'll show you the other places that are involved at the moment, are trying to build this learning health network for kids, adolescents, and adults with every flavor of bipolar disorder you can think of, right? It's not like, oh, you have to have this criteria. And how do we make it so that all of these processes, screening, diagnosis, tracking, population management, guideline concordant care, the actual experience of people who have to be hospitalized, and how do you make that better? And how do you make it better after they're discharged? And how do you also make it so that they can get evidence-based therapy, right? So this is really what we needed to do. And it took a lot of meeting of the minds with clinicians, researchers, patients, families, advocacy groups to come up with, this is our purpose, right? This is the purpose of the Learning Health Network. And this has been our North Star of what we are all about and what we are trying to do. And what I also learned from my colleague, Peter Margolis, who learned it from one of his colleagues, Paul Batalden, is that the results we're getting is a result of the system design. It's the way the system is designed. And that what we have to think about is, first of all, how is the system designed? And what can we do within that system to actually get better results so we have a better system, right? And one of the things in this journey is that I learned, and it was very hard to find anything about this, that outcomes for bipolar disorder essentially have stayed flat for the past 20 years. Right? The outcomes 20 years ago, same outcomes that we're having now. And so that really made me think of, well, we've had changes in treatments and changes in what's available. I mean, why aren't the outcomes better? What are we doing? And what could we do to at least try to get better outcomes? And the other thing I found out in terms of results, and let me just see one thing. Yes, I do have it. I'll show you in detail some of these results in a moment. But one thing that's been frustrating to me as a clinician, right? I'm a researcher, I'm a clinician, is that it is not often that I read a paper that actually changes what I do, certainly nothing that changes the system of care, or that can get better outcomes. I mean, I just don't see that. But let me show you two things that were really a surprise to me. One is this very nice study from Peter Zandi and colleagues at the National Network of Depression Centers, and they have a big mood outcomes program. And it's they looked at all the patients coming in with depression. The bottom one is unipolar depression. The bottom line in gray, unipolar, and top in black is bipolar. I'm sorry, the gray is bipolar. That's at the bottom. And they use the proportion of patients who have PHQ-9 of greater than 10. So everybody starts out depressed, and 2 years later, 60% are still depressed. 60% are still depressed 2 years later, right? With the best treatments that we have, or who knows how they're treated, right? It's like, wow, that's stunning. How can it be 60% are still sick? Yeah, it's amazing. The other thing is that there's been this really interesting pharmacoepidemiology study that Greg Ree and I did together. He was kind enough to invite me to be part of the study. But there's been a huge increase in antipsychotics, and there's been a huge decrease in lithium. And is that good? Is that bad? What are the outcomes from that? Well, we don't have any better outcomes, so who knows what's going on, right? So this is part of what's going on. The other thing is that in terms of psychotherapy, well, in terms of guideline-informed care, I mentioned that before, most people don't actually use measurement-based care, right? Which is not just measuring, but it's what do you do with the longitudinal data to understand how to make the best decision for your patients. Evidence-based psychotherapy, not, for bipolar disorder, right? For bipolar disorder, not use that often. And as I mentioned before, systematic assessment, well, it's one thing to do it in a study. It's one thing to do it with a structured clinical interview for diagnosis. Another thing is like, how do you do that in clinical practice? Who's going to do it, right? That's a whole nother thing. And I mentioned this before, it's a fragmented system, and that the system, mostly what we have, is a dyadic clinician-patient. That's it, right? That's the end of the story. And how do we have it more team-based and more collaborative? So to improve these processes, have systematic screening, systematic diagnosis, and so forth, including care navigators, peer support, and population management so you can understand what happens. That's why we're building the Bipolar Action Network. So across the network, we have global expertise. We have the repository of evidence, tools, best practices for changing care. In other words, what are the techniques that you can actually change the system of care, starting small and then expanding it up? The people who do systems change are really amazing, and they know how to do that. And then we're co-producing this with people who live with bipolar disorder, and that collaboration has just been remarkable. They are initiating all sorts of projects to make things better from their point of view, especially in terms of peer support and some other things they're doing. Now, one of the things with the data, it goes in once and it's used three ways. One is for improving clinical care, monitoring it and so forth, for actual quality improvement, and again, not to beat people up, and for research. We also spent a lot of effort where people can get reimbursed for these activities for non-patient facing care. And that changed in January for the better. And there are these CPT codes that now for these team-based activities. We also have community collaborations. also with policy impact, particularly with the Kennedy Forum. That's different Kennedy, and also opportunities for grants, CME, maintenance of certification. These are the participating organizations that we currently have who've agreed to do this, and these are our partners from the advocacy groups and also the Kennedy Forum, which is Patrick Kennedy and his colleagues, to try to make things better. So if you summarize it all up, right, there are advantages to the health systems, to the clinicians, and for research. With the health systems, improved outcomes, where you can actually measure what's going on, track it, and then figure out where are the pain points. What is it that we need to make better that's not doing well? We also are building a scalable system for not just bipolar disorder, but it could be a prototype for other mental health conditions. The collaborative expertise, think of it as crowdsourcing, right? Think of it as Wikipedia. Think of it as really a TripAdvisor, right? Of really shared knowledge and shared observations that we can do better together than we could possibly do alone. And that also there's the sustainability aspect of it. These are not cheap to run. We have initial philanthropy, but basically because the healthcare systems have understood the value for them and their patients and their clinicians and their system, they're willing to pay into it to help support it. And we could always talk about that a little later in the discussion that we'll have briefly. The clinicians can provide better care, right? That's why we're all in it. We want to help our patients as much. There are amazing opportunities to collaborate and also professional development, including maintenance of certification and advanced training. And then there's research. We will eventually have a very robust database. We anticipate tens of thousands of people followed, both in kids, adolescents, and adults, that can be used for research. It can give a competitive edge to the researchers and for grants and also for professional growth. So that's the Learning Health Network. That's the Bipolar Action Network. And I'd love to hear your thoughts, your questions, your own observations as you think about your own practice and how do you know what you know? How do you learn? How do you change things? How do you make things better? And again, I'd love to hear from the audience. So thank you for your attention. If you could raise your hands, how many of you know the outcomes of your patients? How many of you could look up what are the outcomes of your patients? How are they doing? And I don't know the outcomes of my patients, right? I don't have any place I could look that up. And maybe I could do it, and maybe it would take tremendous effort and in terms of going to the IT people or trying to figure out where I get that data. And one of the things that struck me is I was trying to do a very small study to look at whether or not people were using a particular weird medication, pimavanserin, and we have a very, very large system. So I found maybe 30 people in the system who had bipolar disorder and were exposed to pimavanserin, and I delved into the charts. And I couldn't tell what their outcomes were. There was nothing there that said, did this work, did this not work, were people better, were not better. And one of the things that we did was we said, we don't want to burden the clinicians with a lot of things they have to do in addition to what they're doing. Could we have a simple measure that would help us know what the outcomes are? And collectively, we came up with, there's a clinical global impression severity scale, which is 3 items and takes 10 seconds to do. And right now, what we're doing is we're trying to help people do it. Like, what's going to make it easier? How can you do it? And then we'll know, hey, what are your outcomes? How many people are you seeing who are really chronically ill, difficult, and so forth? And so I hope you can think of what would be the value to you to know the outcomes of your patients. And would it be helpful to know of the patients you're going to see that week, how many are having a hard time? How many could you use a consultation for? What do you need to do differently? Because, again, I never thought that way before. And it sounds like, at least in the audience, you all think the same way. I mean, it's like, gee, I never thought I needed to know the outcomes of my patients, but that could be helpful.
My name is Dr. Andrea Huntley. I'm one of the adolescent psychiatrists here, and we appreciate your presentation. One thing I always talk to the residents about is how hard it is with diagnosis with bipolar in our adolescent and children. And you mentioned something that they're used in this. Is there any sort of screening tool? Because one other thing you mentioned is how we've changed medications and changed more to the antipsychotics, but things aren't really better, or it's about the same, I guess, is kind of what you said earlier. Is there anything you recommend in that population?
So it sounds like there are two parts of your questions, and thanks so much for asking them. The first is like, you have a problem, right? I'm an adult guy, right? you have a huge problem of diagnosis in those kids, right? And it turns out that Bob Finley and Eric Youngstrom have a way to verify the diagnosis in kids with two simple instruments. And we are going to test that and to see if it actually helps and if people can actually deploy it. So we think a fairly simple set of instruments can verify the diagnosis. And in addition to the usual sort of narrative and trying to understand what people are going through. But, the same thing is true for treatments. Like, as you know better than I know, right, there's the rise of the antipsychotics in the kids. And that can be helpful, and it can also cause problems. Bob Finley actually did the only study that I know of that looked at lithium in these kids, and it looks like it helped. But, lithium is not easy to use either. And so what do? I mean, do you give lamotrigine? Do you give N-acetylcysteine? Do you give omega-3 fatty acids? And what do you do for the long run for these kids? So these are the types of things that we need to answer. And we can't just wait for the randomized clinical trials to answer them. We can actually look at the outcomes and see what is going on, try to understand if people have innovative things to do. Does this sound like that would address what your concerns are?
Yes, it would, because we worry about diagnosing these kids and the long-term side effects, especially the atypical antipsychotics and even lithium. But what is treating these patients and who is getting better would be helpful to know. Yeah,
and you have the additional problem of what's the DMDD thing, right? Of like, what the heck is that? You also have the problem of comorbid ADHD, conduct disorder, oppositional defiant disorder, other developmental disorders on top of it, right? I mean, you have a kid who gets manic. It's like there are other problems that the kid has. And then you also have the problem when they become adolescents of substance use, right? Ranging from tobacco to everything else. One of the things I'm really excited about is that we have somebody from the National Institute of Drug Abuse who's going to be joining our group to help us with the comorbid. What do we do about comorbid substance use? And how do we have something that's systematic to be able to do this, right? And this is really the promise of our collaborating across multiple systems. And by the way, we have several places that only focus on kids and adolescents, right? We have Nationwide, we have Cincinnati Children's, we have Virginia Commonwealth, and we also have Manpreet Singh at UC Davis. My actual point is, if this is something that sounds interesting to you, I'm happy to have discussions with you and your leadership about whether or not this would be of interest. Because otherwise you're really stuck with, huge problems that you can't solve on your own.
All right. Thank you, Dr. Nierenberg. Excellent.
Thank you all.